Welcome to this custom deep dive. I want you to start by just taking a second to picture a delivery room.
Okay.
For most of us, bringing a new life into the world is universally understood as an incredibly vulnerable time.
Right. Absolutely.
It's this moment that requires safety and precision and care. But what happens to that incredibly vulnerable moment when the world just outside the delivery room doors is quite literally falling apart?
It's a profound contrast. You have the fragile beginnings of life happening right in the middle of chaos, destruction, or complete systemic collapse.
Yeah.
And until very recently, it has been surprisingly difficult to actually quantify how much that outside chaos impacts the survival of the people giving birth.
And that brings us to the core of our source material today. We are looking at a brand new technical brief and news release published in February 2026 from the World Health Organization and HRP.
Which stands for the Human Reproduction Program, right?
Exactly. It's a special UN and World Bank initiative focused on reproduction research. And the mission of our deep dive today is to explore their startling new data connecting global conflict and health system stability directly to maternal death rates.
It's vital data.
But we aren't just going to look at the grim statistics today. We are also going to uncover how frontline healthcare workers are innovating to save lives right now, in real time, in the world's most dangerous places.
Which is such an important balance to strike. I mean, the data we are going to look at is heavy. It's tough. But the resilience detailed in this brief is equally powerful. It is a very comprehensive look at a deeply human issue.
Yeah, heavy is the right word. Because the sheer scale of the numbers they found is, well, it's where we need to start. The brief reveals that nearly 2/3 of all maternal deaths worldwide happen in countries marked by conflict or fragility.
2/3.
That proportion alone should just make anyone pause.
Totally.
It completely shifts how we need to think about maternal health care on a global scale. We aren't just talking about a few outliers. Okay, let's unpack this, because the raw numbers from 2023 are staggering. In that single year, an estimated 160,000 women died from preventable maternal causes in these fragile and conflict-affected settings.
That's just in 1 year.
1 year. To put that into perspective for you, that is 6 out of every 10 maternal deaths globally. But the disproportionate nature of this is wild. These volatile countries, they only account for about 1 in 10 of global live births.
Right, so you have 10% of the world's births resulting in 60% of the world's preventable maternal deaths.
It's a massive imbalance.
And what that disparity actually means for an individual person is horrifying. The WHO data shows that a woman living in a conflict-affected country has a maternal mortality risk that is around 5 times higher for each and every pregnancy she undergoes compared to a woman living in a stable country.
5 times higher, just by virtue of geography and, where she happens to be living when she gets pregnant.
Exactly. And if we connect this to the bigger picture, we really have to look back at the historical data. Last year, the estimates covering the period from 2000 to 2023 showed that global progress on reducing maternal mortality had practically stalled out.
It just flatlined.
It flatlined. And this new brief explains the mechanics of why. The progress stalled specifically because the numbers remained staggeringly high in these low-income and crisis-affected areas. The global average simply cannot improve when the most vulnerable places are experiencing a 5 times multiplier on mortality.
That paints a really clear picture. We were looking at a global average and basically missing the fact that the crisis zones were completely skewing the data.
Exactly.
I want to dive into the specific categories the brief uses. They talk about these fragility classifications, but before we hit the numbers, what actually separates an institutionally fragile country from a conflict-affected one?
That is a crucial distinction to make. When the brief talks about institutional and social fragility, it usually means the government is essentially bankrupt, institutions have collapsed, or there is severe social unrest.
So the system is broken, but it's not a war.
Right. The basic services aren't functioning, but it's not necessarily an active war zone. A conflict-affected country, on the other hand, involves armed violence, active warfare, and physical destruction of infrastructure. Both are incredibly dangerous. But the mechanisms of danger are slightly different.
That makes the numbers much easier to digest. So let's walk through these specific maternal mortality ratios.
Sure.
The brief uses MMR, which is calculated as the number of deaths per 100,000 live births. In what the WHO classifies as stable countries, the MMR is 99 deaths per 100,000 live births.
Which is still 99 too many, of course.
Exactly, 99 too many. But that is our baseline for stability. Then, in countries considered institutionally and socially fragile, that number jumps to 368 deaths per 100,000 live births.
A huge leap.
And finally, in conflict-affected countries, it skyrockets to 504 deaths per 100,000 live births.
Going from 99 to 504 is just a massive chasm in safety.
Think about it like this for you listening. Imagine the varying risks of driving a car. Driving a car always carries some inherent risk, right? Just like pregnancy.
That's a great way to frame it.
Thanks. So in a stable country, it's like driving a reliable car on a freshly paved modern highway with guardrails, clear signs, and emergency services waiting just off the exit if you happen to need them. Your risk is relatively low.
Because the environment is controlled.
Right. Now, in an institutionally fragile country, it's like driving that exact same car. But now the road is full of massive potholes, the traffic lights don't work, and there are absolutely no guardrails.
The risk goes way up.
But in a conflict-affected country, it is like trying to drive that car on a crumbling, chaotic cliffside road during a hurricane with boulders falling and you have no headlights. The physical process of driving the pregnancy itself is the exact same, but the environment around you has completely destroyed your odds of arriving safely.
That is an incredibly apt way to visualize what these health systems are going through. A crisis destroys a health system's ability to consistently deliver basic life-saving care. You lose the guardrails, you lose the emergency services. The basic infrastructure just isn't there when something goes wrong.
Yeah.
And the brief points out something else critical here. The environment is the crumbling cliffside road, sure, but who is driving the car matters too.
The brief mentions that a pregnant person's risk is compounded by intersecting vulnerabilities. What does that look like on the ground?
Well, it means that the risk isn't distributed equally even within those fragile settings. Factors like gender, ethnicity, age, and migration status all stack on top of each other to increase the danger.
It's a compounding effect.
Exactly. A marginalized teenager who has been forced to flee her home in a conflict zone faces a profoundly different, much harsher reality than someone who is older, has financial resources, and still has a safe shelter in that exact same zone.
Which brings us to perhaps the most heartbreaking statistic in this entire release. The brief compares the lifetime risk for a 15-year-old girl in the year 2023. Let's really listen to this. For a 15-year-old girl living in a stable country, her lifetime risk of eventually dying from a maternal cause is 1 in 593.
A number that reflects the benefits of functioning healthcare systems and rapid emergency interventions.
Now, if that exact same 15-year-old girl lives in a fragile territory, her lifetime risk leaps to 1 in 79. And if she lives in a conflict zone, her lifetime risk of dying from a maternal cause is 1 in 51.
1 in 51.
It's hard to even wrap your head around.
It is. Geography and political instability are literally dictating her chances of survival. It highlights a massive failure in global equity.
It can feel really overwhelming to hear numbers like 1 in 51. It feels like this unstoppable tidal wave of systemic failure. But here's where it gets really interesting.
Solutions.
Yes, the WHO and HRP didn't just publish this data to point out the problem. This brief is actually a roadmap of solutions. They took us on a global tour of how frontline teams are literally maintaining maternal care against impossible odds. And we are going to spend some real time on these because they are incredible.
They really are inspiring case studies.
First up is Colombia. The brief highlights how they are focusing on training traditional birth attendants. My question is, why focus on traditional attendants rather than trying to build more formal clinics?
From an analytical standpoint, this is a brilliant adaptation. In certain regions of Colombia, you have massive geographic barriers, dense jungles, and areas where active insecurity makes travel extremely dangerous.
So you just can't get to a hospital even if there was one?
You simply cannot rely on centralized hospitals because people can't get to them.
Yeah.
Furthermore, you have to factor in historical mistrust. In some fragile settings, indigenous or rural populations might not trust formal institutional health facilities, even if they could reach them safely.
So the system has to adapt to the people, not the other way around.
Precisely. By training traditional birth attendants, Colombia is strengthening trusted existing local networks. They are taking people who are already embedded in the community fabric, who already have the trust of the pregnant women, and equipping them with life-saving medical knowledge and supplies.
That makes so much sense.
They are bringing the care directly into the community rather than demanding the community navigate a dangerous environment to reach the care.
Working with the reality on the ground, rather than wishing for a different reality. Now, let's look at Ethiopia. There, the focus highlighted in the brief is on reestablishing care through mobile teams, renovating facilities, and deploying additional midwives. What does that actually look like for someone seeking care?
Well, when a crisis like internal conflict or massive displacement destroys a local clinic or forces an entire population into a displaced persons camp, you have to mobilize the care.
You bring the hospital to them.
Right. You can't just wait for peace to rebuild the brick-and-mortar hospital. Mobile teams and extra midwives are practical measures to restore continuity. It's about agility.
Hmm.
A mobile clinic can travel to where the displaced people are currently sheltering, provide prenatal checkups, identify high-risk pregnancies, and handle safe deliveries. The healthcare system has to move as quickly as the population it's trying to serve.
Agility is the perfect word for it. And speaking of agility in the face of absolute chaos, the case study from Haiti really stood out to me.
Of the power grid issue.
Yes, the brief talks about how they are removing.
It's the difference between a successful surgery and a tragedy.
I want you to imagine this. You are pregnant. You are displaced from your home because of a severe crisis in Haiti. You find out you need an emergency C-section to survive, which is terrifying enough on its own. Now imagine getting to a facility, and they can't perform the surgery because the power grid is down.
A nightmare scenario.
Or they can perform it, but the cost is utterly impossible for you to pay.
It's a stark reminder that infrastructure barriers and financial barriers are just as lethal as medical complications in these settings. Haiti showing that by simply removing the cost barrier and guaranteeing that the lights and the surgical equipment stay on, perhaps through solar power or dedicated backup systems, you instantly make life-saving care available to women who would otherwise have zero options.
It's so practical, yet so deeply impactful. Now, I'm looking at the next group of case studies in the brief. Myanmar, Papua New Guinea, and Ukraine. Those seem like three wildly different situations on paper.
They are very different contexts.
Right, you have a military coup, massive geographic and social challenges, and a full-scale international war. Why would the brief group them together?
They're grouped together to demonstrate the power of system reorganization and grassroots empowerment. When a nation is under extreme pressure or conflict, the central government in the capital city might become completely paralyzed.
They lose the bird's eye view.
They cannot micromanage the healthcare needs of every single town. What these countries are doing is empowering local grassroots leaders to make decisions. The brief refers to this as subnational planning.
Okay.
It allows for much quicker, more relevant decision-making by the people who are actually on the ground seeing the crisis unfold in their specific region.
And the brief also mentions reorganizing patient pathways in these specific countries. How do you shift a patient pathway when, say, a bridge is blown up or a hospital is suddenly on a front line?
It requires intense pre-planning and flexibility. If Hospital A is suddenly in a conflict zone or the road to get there is impassable, the local health system needs a flexible, established pathway to immediately redirect pregnant women to Hospital B.
You can't be figuring that out on the fly while someone is in labor.
Exactly. They have to ensure that medical records, if they exist, can be transferred and that the receiving facility knows they are coming. It is about actively engineering workarounds so that patients don't just fall through the cracks of a broken system.
It's like rerouting traffic around a downed bridge, but the stakes are life and death. The resilience of the patients trying to navigate these systems, combined with the sheer force of will from the healthcare workers maintaining these pathways, is nothing short of heroic.
Heroic and deeply pragmatic. They are taking whatever broken pieces of the system they have and engineering a way to make it work.
So what does this all mean? We have this incredible disparity in risk, and we have these pockets of brilliant innovation on the front lines. Where does the global health community actually go from here with this new brief?
This raises an important question about resource allocation. For decades, global health initiatives have tried to tackle maternal mortality, but as we saw, the progress stalled. What this new brief provides is a highly precise targeting tool.
Because they finally have the data mapped to the fragility.
Yes. By explicitly linking the maternal mortality data directly to these specific fragility classifications, organizations like the WHO, HRP, and their partners can stop guessing. They now know exactly where health system strengthening is most urgently needed, and they outline three very clear urgent priorities for using this tool.
Let's break those down. What is priority number one?
Priority 1 is investing heavily in primary health care to keep essential maternal services running during a crisis. It's about ensuring the foundational level of care doesn't collapse the moment a shock hits the system.
So even if the big central hospital is overwhelmed with casualties, the primary care clinic in the neighborhood can still do prenatal checkups or safe routine deliveries.
Exactly. You decentralize the basic care.
That makes total sense. What's the second priority?
Priority 2 is strengthening data collection in hard-to-reach places. The brief is very explicit about the goal here, to ensure no death goes uncounted.
That feels incredibly poignant. But I imagine it is incredibly difficult to execute. How do you actually count deaths in a war zone when populations are fleeing and infrastructure is gone?
It is one of the hardest challenges in public health. Counting deaths in a stable environment usually happens automatically through hospital records or civil registries. But in a war zone, the hospital might be rubble, the civil registry office might be abandoned, people are on the move.
So the data just vanishes.
It does. So frontline workers have to use novel methods. They rely on community reporting networks, speaking with village elders or traditional birth attendants to track what happened to the women in their care. They use mobile technology to securely transmit health outcomes from remote, displaced camps back to centralized databases. You have to actively go out and find the data where the people are.
Because it's hard to solve a problem if you don't even know the true scale of it. People are dying in the shadows of a conflict zone.
Data drives policy, and it drives funding. If a population is invisible in the data, they will be invisible in the budget.
Wow, that is a powerful way to frame it.
And then finally, priority 3, designing resilient health systems that can absorb massive shocks and adapt on the fly. We have to stop building systems that only work under perfect conditions.
We need systems that assume the cliffside road might wash out, to go back to our earlier analogy.
Right.
Well, we've covered a lot of ground today. We started by looking at that massive 5 times multiplier, that harsh reality that nearly 2/3 of preventable maternal deaths are happening in conflict and fragile zones, heavily skewing global statistics and leaving a 15-year-old girl in a conflict zone with a 1 in 51 lifetime risk of maternal death.
It's a sobering reality.
But we didn't stay in the dark. We traveled to Colombia, Ethiopia, Haiti, and beyond, seeing how local traditional networks, mobile teams, and simply ensuring the electricity stays on for C-sections are saving lives right now.
What's fascinating here is that the overarching takeaway isn't despair. It's proof of concept. The data definitively shows that even in the world's absolute most challenging, volatile environments, preventable deaths truly are preventable.
You just have to build the right system.
It just requires the right system-level adaptations and a refusal to give up on the most vulnerable.
I couldn't agree more. It proves that the human spirit, combined with smart, targeted data, can literally outmaneuver a crisis. And that brings us to a final thought I want to leave you, our listener, to mull over today. We've seen how crucial these adaptive strategies are in places currently facing conflict or fragility.
Yeah.
But if traditional global health models have historically relied on the idea of stable hospitals and perfectly predictable supply chains, how might the increasing frequency of modern crises, like climate-driven disasters and shifting global conflicts, force us to completely redefine what a hospital or healthcare system even looks like for the next generation of mothers everywhere?
It's a question we all need to be asking.
If stability is no longer guaranteed, maybe adaptability is the only true safety net. Thank you so much for joining us on this deep dive. Keep asking questions, keep staying curious, and we will catch you next time.